ಹೇಳಿ ಬಾ ಯಾರಿಗೂ ಬೇಕಂತ ಹೇಳು. ನನ್ ಸಾರ್ ಕ್ಲಾಸಲ್ಲಿ ಇದ್ದಾರೆ. 1 ಗಂಟೆ ಬರುತ್ತೆ. ಬರ್ತಾ
Good
ಮುಕ್ಕಾಲ್
morning
ಗಂಟೆ
to
ಮೇಲೆ.
everyone present here with us today. This is Trion from IJCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned Professor Dr. Mohan Kotnur Rao. Sir is MBBS, MD, DTCD, Professor and HOD of Respiratory Medicine at Shaptagir Institute of Medical Science. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is treatment challenges in a patient with allergic bronchopulmonary Aspergillosis. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Thank you. Thank you. Good morning to all the viewers. Good morning to all the viewers. Today I am going to talk to you briefly the overall presentation of aspergillosis and mainly stressing on allergic pulmonary bronchial aspergillosis. The aspergillosis is a fungi which there are around 1 lakh species, of which only 100 species are known to cause disease in the human beings. They mainly harvest their nutrition from dead and decayed matter or from the parasites. Okay, what we call human fungal diseases, we call it as mycosis. Okay, but the name Aspergillus is been derived from the microscopically the Aspergillus filament fungi will look like this instrument used by the Catholic priests sprinkling holy water. That's why it was given name as Aspergillus. Okay, it's a sporulatic a fungus. There are 100 Aspergillus species. Among these, 20 species are pathogenic, of which the main are Aspergillus fumigatus, which is the most common one. Others are Aspergillus flavus, niger, terres, and nidulans, of which the flavus, terres, and nidulans are resistant to some of the antifungals like amphotericin B. Coming to the morphological characters, macroscopically they appear like colonies. Microscopically, when you see, they are 4 to 6 millimeters wide hyphae with parallel walls and distinct septa. And at the end, it's a club-shaped one which is releasing the conidia or spores. They branch dichotomously at 45 degrees angles. So this is how you can look the aspergillus look at the microscopy. Okay, coming to the clinical spectrum of the diseases produced by the aspergillus species are, it can be just a hypersensitivity reaction. In this, again, it can be just a simple bronchial asthma type of presentation, or it can be an allergic bronchopulmonary aspergillosis, or it can be a bronchocentric granulomatosis, or it can be just a extrinsic allergic alveolitis. Sometimes the aspergillus can grow as and live as a saprophyte in the human lung. Then it can cause a tumor-like thing within the cavities, which we call it as fungal ball, mycetoma, or aspergilloma. Whereas in some special conditions where this aspergillus will invade the pulmonary system and it can cause like invasive bronchopulmonary aspergillosis or chronic pulmonary aspergillosis, it can cause. So the aspergillus, depending upon the immunity or the coexisting comorbidities in a patient or genetic conditions, it can cause wide spectrum and the diseases like a simple bronchial asthma to invasive pulmonary bronchopulmonary invasive pulmonary aspergillosis. Okay. Now, suppose if the patient is an atopic individual who has got a history of atopy, then the inhalation of these Aspergillus spores can result into a IgE-mediated allergic immunoreaction, which is driven by T2 cells, immunosystem like CD4 response, which can cause a bronchial asthma attack and excessive mucus production can be made. If the patient is a non-atopic individual, the persistent colonization of Aspergillus in these patients may lead to hypersensitivity pneumonitis, or we call it as extrinsic allergic alveolitis, okay, or farmer's lung, what we call it. This is a Th1 driven immunoreaction. We are also again by the mediated by the CD4 Th cells. Okay. No. Coming to the hypersensitivity reactions to Aspergillus. We have discussed it can be a simple asthma or it can be a aspergillus, allergic bronchopulmonary aspergillosis, or it can be extensive allergic alveolitis. How each one differs? Because a patient comes to you with a history of asthma, and that too, if it is a prolonged and it is persistent, then you have a dilemma. Whether is it a bronchial asthma, what type, what phenotype, what is it? Or if it fits into ABPA, or it fits into ABC. So coming to if it is a pure, if the Aspergillus is causing only asthmatic type, the pathology is usually in the airways, it is a hypertrophied mucus glands. The radiological features, if it is simple asthma, the X-rays may be normal even in the early stages or undistinguished, or it can go in for a hyperinflation, which is because of the expiratory obstruction of the airways. Okay. Whereas in this asthma, the skin tests for Aspergillus antigens may be immediate ones are positive. Immediate skin test for Aspergillus antigen is positive, whereas delayed the response to Aspergillus antigens skin reactions are negative. Peripheral eosinophilia may or may not be present. And serum precipitants for IgG antibodies for Aspergillus precipitants is usually positive in if it is simple asthmatic presentation. Serum IgE levels are normal or mildly elevated if this is a simple asthmatic presentation by suppose if it is ABPA, that is allergic bronchopulmonary aspergillosis, this is because of colonization of this fungus in the airways, which causes immune response in the airways, causing lot of mucus production with increasing dehydration. This forms thick mucus plugs, which can impact and sometimes may block the airways. Okay, that is the main pathology in ABPA. There is also tissue eosinophilia. So eosinophilia is present both in the blood and also in the test biopsies. Okay, radiological features, please mind the characteristic features are they are migratory peripheral infiltration. Means the patient, the X-ray shadows are present at a certain time. If you take a X-ray for the next time, it may disappear at that particular area and it may come into the other place. Other radiological features include atelectasis and bronchiectasis if this is prolonged. If it is late, slightly prolonged, then it can lead to fibrosis. Okay. Here, the skin tests for Aspergillus antigens are both early and delayed are positive. Okay. Whereas peripheral eosinophilia is definitely present. Then if you take a serological test for precipitants to IgE Aspergillus antigens again is positive. Serum IgE levels are markedly elevated. So whenever a patient comes to you with repeated attacks of bronchial asthma with mucus production, if he gives history of bringing out CAS, means plugs, During the expectoration, you have to suspect if it is chronic, you have to suspect ABPA and you do the test particular for one. One is serum IgE, look for peripheral eosinophilia and do skin test for Aspergillus antigen and LC for serological test for antibodies, IgG antibodies. Okay, so this will clinch you for your diagnosis. Whereas if it presents as an extrinsic allergical, especially in farmers' lung, those who are exposed during their this one and they are non-atopic, here the main pathology is it is the infiltration, lymphocytic infiltration, whereas in ABPA it is eosinophilic. Where here it is lymphocytic infiltration. The X-ray shows diffuse alveolar and interstitial shadows. Lately, they may become as a present as a reticulonodular interstitial opacities. Okay, here both the skin test for early and late for Aspergillus antigen is positive. Peripheral eosinophilia is particularly negative. IgG antibodies may be positive. So you can differentiate what type of Aspergillus reaction, hypersensitive reaction this patient is in, taking a repeated history, do a chest X-ray, do a IgE and eosinophilia, peripheral eosinophilia, and then skin test, and then IgA antibodies in the serum. It will give you which type of hypersensitivity reaction to Aspergillus we are dealing. Next, now coming to the main topic, allergic bronchopulmonary aspergillosis. It is an idiopathic inflammatory disease of the lung characterized by allergic inflammatory response to the colonization of the airways by Aspergillus fumigatus. Because of chronic asthma, there is a chronic inflammation going on, which will become a good nidus for the colonization of these Aspergillus. The risk factors include atopic individuals, bronchial asthma, as we have discussed earlier, the mutation of CFTR gene, especially cystic fibrosis patients, whereas history of environmental exposure, if the patient is an atopic individual, if he is exposed to organic dust in the farms where the Aspergillus is present, again it may precipitate allergic bronchopulmonary aspergillosis in those individuals. Okay, so coming to the pathogenesis, once you are repeatedly exposed to Aspergillus, they will colonize, persist for some time, for regularly, and they start germinating. This growth of hyphae and the inflammatory exudate will cause form the mucus plugs, which can be expectorated. If they become very thick and the fluid is dehydrated or fluid is removed from the lungs, like because of hyperventilation, they will become thick plugs which can block the airways. Okay. Once these plugs are there, there is an inflammatory reaction which inflammatory cells are infiltrated into these mucus plugs and into the airway L walls. They release proteases and the toxins. Okay. These proteases and toxins compromise mucociliary clearance. Once it breaches the airway epithelial barrier, they activate the immune system, going to the regional lymph nodes and locally. The initial reaction is IgE mediated. So the IgE molecules which are released, they bind the mast cells and release many inflammatory cytokines which can trigger a bronchial asthma type of reaction. Okay. Again, in this instance, there are the release of neutrophils also. These neutrophils again release mediators, cytokines 4, 8, 13, and others, which cause vasodilatation. And then there is a leakage, and then further accumulation of neutrophils and release of IgG, and which reacts to IgG antigens, and which can form a complex. They both IgG and IgE responses can be seen in ABPA inflammations. Okay. This is how A thick mucus plug excreted from the a patient with a ABPA looks like. You see, they are all these branches, or they are expect from the bronchial branches where they have blocked, and then this patient these are, say, divisions of the bronchi, peripheral bronchi can be seen. Okay, what are the clinical features? Nearly all patients with ABPA have history of chronic asthma. What are they? Patient will have cough, expectoration, chest tightness, wheezing, episodic to start with. Later, they become continuous and persistent, like a chronic persistent asthma. When these attacks are becoming very frequent and nearer, the patient will have weakness, malaise, low grade of fever, cough with expectoration. In addition, if there is a secondary infection, patient will have change in the color of his sputum. If the patient has got a damaged lung already, like bronchiectasis or CF, cystic fibrosis, they may go in for secondary bacterial infection with like gram negative. So then the color of change may be greenish pus can be there. If the bronchiectasis is peripheral and it is involved in the patient may have diffuse or localized chest pain, recurrent pneumonia we have discussed because of the repeated infections, and patient may give history of frequent use of antibiotics. So a patient with a repeated attacks of bronchial asthma, change in color of the sputum, you have to think, and if he has got an atopic history, you have to think whether we are going to deal with an ABPA patient. Okay. The mucus plugs are formed in the bronchial bronchi. Because of mucus, they can cause atelectasis. When they become very thick and they completely block the bronchi, then the distal atelectasis can occur. Okay. Coming to the radiological features, you may have a transient pulmonary infiltrate. If it progresses, it can lead to bronchiectasis, bronchoria, hemoptysis, and clubbing because of chronic hypoxemia can be seen in this patient. If the patient has cystic fibrosis, the ABPA presents as either hemoptysis or sometimes a pneumothorax, which can go in for tension pneumothorax. So, coming to the radiological features, the main is that to start with, there will be pulmonary infiltrates, which are transient initially. They can progress to permanent radiographic changes as the disease progresses. Means if you take an X-ray, if you have seen X-ray, if you take his other X-ray after some time when he presented, the initial lesion might have subsided and there may be a new lesion in other areas of the lung. So that is transient fleeting airways. Ring sign or signet ring sign, which is characteristic of bronchiectasis. Gloved finger or finger in glove appearance because of the opacification of the dilated bronchi because of mucus impaction. Proximal bronchiectasis, which is characteristic for ABPA. This is normal filling of the bronchi distal to the saccular bronchiectasis lesion. That's a hallmark of ABPA. The ABPA lesions start with maybe focal. They may, as progresses, it may become bilateral, usually most commonly seen in the upper lobes. This is how this first X-ray of a patient where we have found a right middle lobe shadows, and then also there is a right upper zone shadow. After 8 months, he has come and they have taken a one more X-ray. There is a different disappearance of the shadows of most of the right upper lobe, whereas the right upper lobe shadow has become much thicker because of mucus impaction. If you take the closer look of this lesion of the right upper lobe, you see it looks like a gloved finger appearance, okay? Like a finger in a glove. And also you can find a cavity with a fluid level, which is nothing but a bronchiectasis. So here you can see fleeting shadow. There is a mucus impaction of a gloved finger and also proximal bronchiectasis, which you can see is a parahilar region. Okay. When it is advanced, it can lead to a cavitation, localized emphysema because of the blockage of it, and then there's a traction bronchiectasis causing the adjacent lung to expand. So there can be a local emphysema, contraction of the lower lips because of the fibrosis, and the honeycomb fibrosis because they are very nearer. They can look like a honeycomb, and the fibrosis cause contraction. So you can see multiple rounded cystic lesions all over. In some, you can find the fluid levels. There is air bronchogram, air trapping, that is the emphysema. Here also you can see. So this, when there is a long standing, you can find the bronchiectasis, which is parahilar. You can see very parahilar region, bronchial bronchiectasis. Okay. So this is practice if there is a progressive ABP. Now coming to the diagnosis of how do you confirm the diagnosis, there are certain criteria which has been described. The earlier one which was called Rosenberg criteria. Here they have given it to primary and secondary. The primary features include episodic bronchial obstruction, that is episodic attacks of bronchial asthma, peripheral blood eosinophilia more than 1,000, immediate type of skin reaction, that is reaction to Aspergillus antigens, and presence of precipitating serum antibodies in the serum to Aspergillus antigens. Okay. In addition, there is a elevated serum IgE more than 1,000, serum eosinophilias more than 1,000, history of parenchymal infiltrates, pulmonary infiltrates, which are transient, and central bronchiectasis as the disease progresses. If these things are present, you have definitely say the patient is having allergic bronchopulmonary aspergillosis. Suppose in some patients who are asthmatic, maybe not severe, but if the sputum is produces, you are demonstrating Aspergillus fumigatus by culture, repeated cultures, and history of expectorating of brown plugs or flecks, and Arthur's reaction, that is type 3 reaction, immunoreaction is positive, then also you can say the patient can be having a low severe type of allergic bronchopulmonary aspergillosis. This is a Rosenberg type. There is another criteria which is recently followed is ISHAM criteria, that is International Society of Human and Animal Mycology. Here, the baseline conditions are asthma and cystic fibrosis. The mandatory criteria to diagnose ABPA are IgE specific for allergic Aspergillus fumigatus is positive, more than 3.5 kilounits per day. A positive SINS test to Aspergillus fumigatus. Total serum IgE is more than 1,000. Are there? You are sure that other criteria, which can at least two should be present along with this, are one is IgG against disease, that is fumigate, antibodies against Aspergillus fumigatus, and the radiological features which we have discussed, like central or proximal cylindrical bronchiectasis, alternating predominantly in the upper lobes, then nodules, atelectasis, and air trapping, and also drop total eosinophil count more than 500. Any of these two, IgG antibodies, radiological features, and eosinophil counts more than 5, along with the above mandatory criteria are present, then we have to diagnose it as a ABPA, that is allergic bronchopulmonary aspergillosis. So any patient, if you are suspecting that the patient is having, the mandatory is you should do IgA specific for allergic Aspergillus fumigatus, a skin test for allergic and total serum IgE. Okay, more than 1,000. And additional features of IgE, radiology, and eosinophil counts you have to be taken into consideration. Okay. Coming to the staging of Aspergillus bronchiolitis, the patient may present in different stages. One, it may be an acute stage, or he may present it at a remission stage, or he may present it during an exacerbation stage, or it can be a at a steroid dependent stage, and in the lastly, it may be a fibrotic stage. Okay. Suppose if the patient is presented in acute stage, what are the things? Here, the patient may have fever, productive cough, and wheezing, like just a bronchial asthma exacerbation can be there. Radiologically, what you can see is you can see pulmonary infiltration and mucoid infarction can be there. Laboratory risk, blood eosinophilia, elevated serum IgE level, and positive skin test can be there. Such patients definitely will improve by using corticosteroids. Okay. Suppose if the patient is presented in a remission, the patient may be asymptomatic, chest X-ray may be normal. If you do the laboratory test, there may be elevated IgE, but it's not to extent. Blood eosinophilia can also be there, normal or increased. And such a patient requires constant follow-up. Suppose if the patient is exacerbation, means he will present it with an acute exacerbation of a bronchial asthma picture. He may have fever, change in the color of the sputum, and he may be having hypoxemia, wheezing can be there, and he may sometimes, if severe, may go in for a type 2 respiratory failure. Okay. The radiological features, all features which we have described in this can be there. There may be mucous infarction, pulmonary infiltrates may be there, central peripheral bronchiectasis, sorry, central bronchiectasis can be there. At that period, if there is a twice the increase in IgE level in an asymptomatic patient, is this from an asymptomatic stage, it is an indication that it is an exacerbation. Double, two times the double. Okay. Then there is a usually elevation of the IgE level will be there. Such people are ones which retreat and with steroids to induce remission. So you have to use steroids. Okay. Whereas in a corticosteroid dependent patient, you may have to use long-term steroids. How we can know? If when you start tapering if there's once you get a control, if the patient is becoming worsening, or he may present with an exacerbation, if such patients are known are the patients who are dependent on corticosteroids. The fibrotics stage, here the patient will be in acute severe dyspnea like a MMRC grade 4. Fibrotic lung diseases can be seen as a bronchospasm. There is fibrosis of the radiology. There is a decrease. In addition, you can also find central bronchiectasis. The peripheral infiltrates may or may not be there because of fibrosis. Okay. So the pulmonary function tests show restrictive and reversible, irreversible patterns of the test. They may have increased IgE levels can be there. So such patients require long-term corticosteroids along with antifungal agents. Okay. Now, once now we have decided whether the patient is either the bronchopulmonary, which stage he has presented, and then see the management. The management includes from stage 1 to stage 4, that usually they are reversible with a long term, without much long term sequelae. Whereas when the patient is presented with a stage 5, it is an irreversible fibrosis with bronchiectasis and may go in for complications of right heart failure, so type 2 respiratory failure, and so. So our goals of treatment should be treating the acute exacerbations, preventing the development of fibrosis and bronchiectasis, and therapeutic modifications depending upon the response to the patients by using whether requires MDIs or oral steroids or systemic antifungals have to be used. We have to take a decision depending upon the severity. Okay, coming to the MDIs, you have to use beta-2 agonists, anticholinergics, and leukotriene antagonists depending upon the severity, and you may use either a nebulized form, MDIs, or this thing depending upon the severity. Coming to the antifungals, the inhaled antifungals like nystatin, amphotericin B, offers only temporary suppression of colonization, but penetration of these agents into the bronchi is very, very limited. Coming to the main treatment of ABPA, it is the oral corticosteroids. Okay. Here we have to start steroids with zero point 0.5 to 1 milligram per kg body weight of prednisolone for 1 to 2 weeks. Later, once the patient has improved, then you have to reduce it to zero point 0.5 milligrams per kg body weight and continue it for 6 to 12 weeks. You can taper later depending upon the response, but some patients who are chronic may require a maintenance dose of 75.5. That's those who are corticosteroid dependent, they may require. Coming to the antifungals, in the aspergillosis, only azoles are in, effective. Whether cascofungins are may not be much useful. Here we have azoles like itraconazole, voriconazole are useful. Itraconazole can be given as 200 milligrams. One, so it can be used in steroid. Newly detected ones, voriconazole and posaconazole, they can be given. Voriconazole can be given as 6 milligram per kg body weight 5e or for first 24 hours. Or you can start oral posaconazole or voriconazole, giving a loading dose of 200 milligrams BD for 3 days, then make it for 200 milligrams OD. Okay. Later 6 milligrams pericardiolite, then go back to 4 milligrams pericardiolite you can give. Okay. Nystatin, amphotericin are ineffective in case of allergic bronchopulmonary aspergillosis. Okay. Now I will tell you briefly about other manifestations like aspergilloma. It is the saprophytic colonization of aspergillus in the lung parenchyma, especially in the pre-existing cavities. Okay, that aspergilloma consists of dead and living mycelial elements, fibrin, mucus, amorphic debris, inflammatory cells, and degenerating blood and epithelial cells. Most of the aspergillus are caused by Aspergillus fumigatus. In type 2 diabetes mellitus, sometimes Aspergillus niger can cause aspergillomas. Okay, so these aspergillomas usually arise from the bronchial tree. If there is a proliferation of aspergillus leading to cavity, this is called as a primary aspergilloma, which is very common. Whereas secondary aspergilloma is more common. It is colonization and proliferation of fungus in the pre-existing pulmonary cavities, especially of the cavitary tuberculosis. Okay. Tuberculosis is the main predisposing factor for aspergilloma or long-standing persistent cavities of large can cause. So here in these long-standing cavities, there is a colonization of the fungus, which may locally infiltrate, may not infiltrate, then it can cause a fungal ball. The main clinical features are, they may be many times they are asymptomatic, only you can find them, or it can be hemoptysis. It can be very minimal, or sometimes it can be life-threatening. Hemoptysis can be there. Other than that, rarely patient can have dyspnea, fever, malaise, and weight loss, which is not that common. This fatality are there, they may be because of the active TB or reinfection TB or TB into sequelae like fibrosis can be there. Radiologically, what you can find is a solid round mass within a cavity, partially surrounded by a radiolucent crescent, which is called a Monod sign. Solitary lesions usually seen in the upper lobes of the lungs. Most common radiologic feature of aspergilloma. Aspergilloma can be bilateral, sometimes it can be multiple. See, radiologically, what you can see is this is a cavity. Okay. Then you can find a meniscus sign, what we call it as. This is a fungal ball. Class, class ಮಾಡ್ತಾ ಇದ್ದೇನೆ. Class ಅಲ್ಲಿ ಇದ್ದಾರೆ. Net ಅಲ್ಲಿ class ಅಲ್ಲಿ ಇದೆ. The systemic or local administration of antifungal agents, surgical resection, conservative management of careful follow-up without specific medical or intervention. Asymptomatic patients with aspergilloma, repeated clinical evaluation and periodic chest x-rays without infection, bronchial artery embolization if there is a severe hemoptysis or life-threatening hemoptysis at a time that you can take this. And bronchial artery embolizations you can take. Antifungals may not be that much useful. You can use a CT-guided percutaneous installation of amphotericin B or endobronchial installation of ketoconazole or fiber optic bronchoscopy. Systemic therapy with antifungal agents for solitary aspergilloma who has severe hemoptysis are contraindicated. Okay, itraconazole 200 to 400 milligrams. Activity against amphibians. Invasive pulmonary, it is usually invasive pulmonary aspergillosis is a severe disease, mainly affecting the severely immunocompromised infants. The risk factors are hematological malignancy, aplastic anemia, the recipients of allergenic grafts, lung transplants, AIDS, burn patients, and who are on chronic steroids. Okay. The pathogenesis includes aspergillus, saprophytic mold, colonizes in the respiratory tract, damages the respiratory epithelium, reaches the mucosal host defense, and may invade the iatrogenic suppression of protective T1 response and invasive aspergillosis, both the bronchi and then it may go to systemically also it can cause. Clinical features, usually fever, mild or non-productive cough, pleuritic chest pain, maybe because of pulmonary infarction, hemoptysis, immunocompromise, there may be a cavitation. Cough, sputum production, they may be absent or very, very minimal. Okay, susceptible patients receiving broad spectrum antibiotics therapy phase, invasive aspergillosis has to be suspected. Extrapulmonary also it can help kidney, liver, spleen, and CNS. Invasive diseases they can locally invade and cause nose, parasynal senses in immunocompromised individuals. It may go as a contiguous invasion into orbit cranial wall. The symptoms like rhinocerebral mucormycosis can be seen. Okay, diagnosis, chest X-ray is not sensitive, detect IPA. HRCT is useful. The HRCT shows small wedge-shaped subpleural lesions or nodules. Halo sign, which is hemorrhagic and edema. Then you can see this halo sign because of the infarct or hemorrhagic edema. There is a halo sign, which is seen within the first 4 to 5 days. Then it may, after 3 weeks, it may become a cavity with a wall. Okay, air crescent sign, it can be seen. Okay, that is air crescent sign. Okay, so what are the therapeutic options to treat invasive fungal infections? Are you have amphotericin B, which is a lipid formulation which is used nowadays. Azoles like fluconazole, itraconazole, and voriconazole and posaconazole. Echinocandins like capsofengin, mycofengin, and grisofulvin, and fuocysteine, others can be used. Of these, only azoles are useful in aspergillus, whereas in candidiasis and others, you can use fungins, amphotericin B, and other things. Okay. So coming to the dosages, you can loading doses, you have to give fluconazole 800 milligrams, other azoles like 200 milligrams BD. Okay, there is conazoles like 200 milligrams for 7 days, capsofungin 70, 150, and 250. Once 2 to 3 days of loading dose, you can use them as daily doses as 200 milligrams BD or like that you can use. Then what are the side effects you can expect when you are treating with an antifungal agent? If it is amphotericin, you find the nephrotoxicity and hepatotoxicity. Azoles is usually rarely cause anaphylaxis. They may use cause of nausea or phototoxicity, cardiomyopathy, and hepatic toxicity can be seen with the echinocandins. Many of them will cause gastrointestinal disturbances. whereas fucosis, flucositine, and rhizophlavin can cause sometimes decreased erythropoietin production, and rash and photosensitivity can be seen. So before starting any antifungal agents, you have to use some of the organ function tests like a RFT, LFT, helpful for evaluation of excretion of the drugs, or is there for the second, if the patient develops later deranged, you can think with it because of the drug induced. The immune status, serological tests, previous bone marrow transfusions, presence of leukemia or lymphoma, you have to be careful by using that. See, previous psychiatric conditions like mood disorders or schizophrenia, it can aggravate these antifungal therapies. Can be so you have to take into account. Previous parasitic conditions, such as antihelminthics, when administered along with antifungals, can cause severe hepatic dysfunction or neurological disorders. So, this is in brief what I have dealt with a spectrum of antifungal diseases, especially allergic bronchopulmonary aspergillosis, how to diagnose, how to treat, and then how you have to take while starting the treatment, what you have to take. So, with this, I will conclude my talk and I am ready to take any questions in this topic. Thank you, please. Thank you.
Thank you, sir. Sir, we
Thank
have a
you.
question if you like to take that up.
Yeah,
So, sir, the first question from our audience is, can you
yeah.
discuss any emerging therapies or clinical trials that shows promises for
Hmm.
ABPA patients?
Yeah, nowadays we have got some this molecular thing. They are still in the investigative stages. Many, some of them like IgA, anti-IgE therapy, have been used, but not typically for the fungus. Suppose if he has got an IgE case, you can use omalizumab, resiplizumab, all those things. They have been used. If you have found out there is IgE elevation, then you can use this monotherapies like IgE, which you can be given once in 3 weeks by subcutaneous routes. They have associated with some of the immediate complications. Once you target, you can start, you can use these things. They are still, because omalizumab, rosuzumab, they are all there in the market. They can be used if the patient with ABPA has got raised IgE levels and eosinophils. Okay.
Thank you, sir. The next question
Thank,
is, how can
yeah.
patients be supported in managing the psychosocial aspects of living with chronic condition like ABPA?
See, ABPA is a chronic morbid condition. Patient will have repeated attacks of bronchial asthma, protein, all those things. So he will be definitely depressed. Okay, so first to explaining him about this condition, and then treating him, taking his confidence, and explaining the morbidity, all those things. Moral support by the physician whenever he visits, and also explaining it to the family attendants, the disease, how it behaves, how you have to support him, will be helpful from this for these patients. Psychosocial visit, definitely these are all chronic morbid conditions. It requires these things.
So there is one last question from our audience.
So,
The last
okay.
question is, how do antifungal agents fits into
Yeah.
the treatment regimens for
Yeah.
ABP, and what are the consideration for their use?
See, I have already told you, if it is a ABPA because of Aspergillus fumigatus and nidus, only azoles are helpful. Okay. In this, we can use voriconazole, itraconazole. Itraconazole can be used orally, loading dose of 200 BD, TID for first 3 days, followed by BD. Whereas voriconazole can be given as 6 milligrams per kg body weight as a loading dose, and then you can make it as a 4 milligrams per kg body weight of 2 days. You can use them in allergic bronchopulmonary aspergillosis along with the steroids, which you can use it. Other capsofungin and the other things, they are not useful. In rare cases, you can use amphotericin B in the allergic bronchopulmonary aspergillosis. If it is invasive, presents as an invasive, you can use amphotericin B. But main therapy is steroids and azoles.
Thank you so much, sir, for answering all our questions. So that's all from our
Okay.
audience, sir. So
Thank
before
you, madam.
concluding, any last
Yeah,
remark?
tell. Yeah.
Any last remark? Any take-home message from
Yeah,
you, sir?
nothing, madam. I think people, the physicians have an idea now what is a bronchobilis, how to go through if you are suspecting if a repeated patient comes with asthma, how you can make what are the radiological and laboratory features which you can take into consideration and the treatment. Okay, so that's so very good. I think I have conveyed some message to the audience who has logged in. Thank you. One more request, madam.
Sure, sir. Sure.
Uh, can you send me one certificate like thing in your IJCP headline that I have presented this from your
Sure,
end?
sir. I will
Okay.
discuss and get back to you, sir.
Yeah,
Thank you
one PDF
so much,
PDF
sir.
form is sufficient because I can keep it in my CV so that I
Sure, sir.
had.
Definitely. Let me
Okay.
discuss and I will get back.